Hi, everybody. Welcome. I am Sarah Clute-Bain, the Boone County Hospital Foundation Director. We have our episode of Educating and Empowering You this month with our several professionals from Boone County Hospital here helping us address women's health services that are available at Boone County Hospital. So excited for this conversation today and to learn from each of you. I do want to say quickly that these programs are sponsored by Boone County Hospital Foundation. And next month we will have the Iowa Donor Network will be with us. So learning about some of the updates with the Iowa Donor Network and really, again, looking forward to speaking with them as well. It's been a long time. It's been a long time also with this group. I know we've had some of our physicians on helping us with women's health in the past. And again, looking forward to being educated today by each of you. So just as a if anybody pops on here and wants to put questions in the chat, or you have anything that comes up, please just put that in the chat. Otherwise, I will be doing my best to moderate and ask questions as we go. So we're going to give an opportunity for each of you to do an introduction. And I'm going to start with you, Dr. Hay, if you would like to get us started with a little background about yourself and then starting to talk about what you do as a family practice physician here at Boone County Hospital and Clinics. Thank you.
Well, thanks for having us, Sarah. So I'm one of the family medicine doctors over at the North Clinic. I do full spectrum family medicine, newborns, adolescents, delivering babies at the hospital, caring for moms, breastfeeding medicine, and then obviously for the entire family, including men who we're not talking about today, but them and women kind of throughout the entire spectrum and age. So the question that been kind of posed to me was sort of what women's health looks like over the entire course of a woman's life. And I think the unique thing for family medicine doctors is we actually get to meet women when they are very little and they're not quite women yet. And I actually think that's when women's health really starts. So family medicine has this unique opportunity to kind of engage with people and create relationships long before we have to do much of what most people consider women's health. So with the very young kids, we're teaching them about the appropriate terms for their body. We're helping to open up that conversation about when they start to have periods, how help mothers and fathers and other family members kind of have conversations about this whole process of puberty and knowing somebody so that if things come up, they feel like they have another adult that they can come and talk to about issues where they don't quite yet have the words to talk to a family member about what they're experiencing with their body or in relationship with other people. So I would say women's health starts really early, maybe as a baby. And so here in our clinic, we'll see adolescents and we start doing STD screening as soon as people are interested, definitely start offering it between the ages of 14 and 16. We start mental health screening around that time period as well, because I think mental health is really important for women's health. And just creating that safe place, start talking about contraception at any point in which somebody is interested in hearing about it. And we offer, medicines to help in talking about people's periods as early as periods start happening, which honestly feels earlier and earlier every year, as early as 7 or 8 years old. So start having those conversations as we develop relationships with families. For most people, we think about pap smears as the first thing that we do for women's health. And so that doesn't really start no matter when you start having sex until you're 21, unless there are new concerns that are going on. We might do a pelvic exam for lots of reasons that are not related to pap smears. And pap smears are specifically looking for cervical cancer or cells that aren't cancer, but were we to leave them there for a long time, 15, 20 years, they could turn into cancer. And so it's a preventative screening in the setting of no symptoms to look for the virus, HPV, that can lead to cells becoming abnormal enough that were we to leave them there untreated, not getting rid of them, that they could turn into cancer at some point in your lifetime. So I think for most of us as physicians, we're not seeing cervical cancer as much because of pap smears, because we can catch things long before they turn into something scary and, monitor or eradicate those sorts of infections that can lead to cancer. So we usually do pap smears every 3 years. starting at age 21. And a pap smear pelvic exam is not required to get birth control or talk about how your periods are going. Sometimes it's part of that exam, sometimes it's not. And we do those every 3 years as long as the pap smear is totally normal. If there's an abnormality on the pap smear, we see that virus. Sometimes we'll do the pap smears more frequently than that, or other testing to see how abnormal the cells are behaving. And then usually at age 30, that shifts a little bit. And if they've always been normal pap smears, we will start checking for the virus itself. And if there's no abnormal cells, that's the pap smear part of it, and there's no virus, we might actually start doing your pap smear every 5 years, which was honestly a big shift for a lot of people who are used to getting pap smears every single year. Most people don't protest when I'm like, oh, we don't have to do it again for 5 years. And then as you approach your 60s, usually if you've had normal pap smears and you've had one within a few years of the age of 65, as long as you're not having any symptoms, you may not need another pap smear beyond that age of 65. The other aspects of women's health, like I mentioned, would be STD screening. We can do pelvic exams for a whole bunch of different reasons, talk about your periods at any point. Breast health is something we talk about, again, as we build that relationship through adolescence into your teens and 20s. Most people don't start doing mammograms until they're 40 or 50 years old, depending on sort of what their family history is and what other risk factors they might have. And we do those here, as I think we're going to talk about in a little bit, our mammograms that we do at Boone County Hospital. Breast exams were something that we did in visits every single time for a long time. And what we found is that we weren't saving lives by doing them. And so we've kind of changed more towards, we really engage with the patient to see what their comfort level is and what they know of their own breasts, and immediately do one if they notice anything or if they have interest in having a breast exam. And so we just have conversations about it. And the same with pelvic exams. Now that we're not doing pap smears every year, you might go a long time without a pelvic exam. And for a lot of people, that's okay. But, as we ask questions about, how's your sexual health? Are you having pain with sex? Are you noticing bleeding? That's outside of your periods? Is there something else going on that we need to talk about? Then sometimes pelvic exams will be part of that. And so that's the mainstay of what we're doing for a lot of women's health. Obviously, I think mental health is a big part of women's health. I think it encompasses a lot more than just pap smears and mammograms. Birth control or period control for anybody who's having periods. And so that's sort of how things go for screening purposes. Were there other specific questions that you had, Sarah, that I might be able to touch on?
Yeah, the only thing that came up for me that I'm curious about is you talked about HPV, and I believe we start those vaccines typically around age 11. Is that correct? Maybe you can expand a little bit on that for us.
Yeah, I think it's amazing that to see what the future is going to hold as far as pap smears are concerned. The idea is that it's really rare to get cervical cancer without the virus that makes the cells start to behave abnormal in the first place. And so the idea is to have all of our children, boys and girls, vaccinated against the virus long before they become sexually active to help prevent cervical cancer. But they also threw in other types of HPV in that vaccine, so it also can help to decrease your chances of genital warts. And turns out about 20% of head and neck cancers are also HPV related. So and it's not unique to just women, and obviously it's a sexually transmitted disease, and so it's something that men can struggle with issues related to HPV infection as well. And so prevention makes the most sense. And so who knows in the future if we're having vaccinated people that are not getting HPV in the future, it might change how often we actually have to do pap smears and screening and those sorts of things.
Great, thank you for expanding on that. That's great. I think that was a very helpful overview, and I think that Dr. Stevenson was going to take us kind of to that next phase in life. Is that correct? Am I correct on that?
Yes, thank you. Can you hear me?
I can hear you.
Okay, great. Yeah, so I was just going to touch on maternity care during the life phase. So this is, in my opinion, one of the more unique phases in medical care, just because it's finite. It has a beginning, it has an end. So in some ways, it's treated a bit like a chronic condition. It's not going to end tomorrow. But you also know, we're not elephants. We don't carry gestation for 40 months. So we know that there's an end to some of the discomforts and challenges that arise during pregnancy. For a lot of people, it's a very unique time, first of all, because a lot of people getting pregnant are starting out fairly young and healthy. So they're not, maybe when you're in your 20s and you're just coming in for pap smears, you're only coming into the doctor every few years. Maybe you're not on any chronic medications, or maybe you come in once a year to get an annual exam, get your birth control refilled. And then, suddenly pregnancy hits and we're expecting you to be at the doctor's office a lot more often. In an ideal world, you might have a conversation with your primary care provider even before conceiving, when it's a little bit on your radar or you're thinking about becoming pregnant. There's certain things we can do as doctors to get your health optimized prior to achieving pregnancy. And it's really wonderful when people come in and they say, hey, I'm thinking about getting pregnant about a year down the road. What should I be doing now? And we can look at your medications and decide, people, particularly on chronic migraine medications or blood pressure medications, there can be some optimization where we put people on preventive medications that are considered safer in pregnancy. We know that when you get pregnant, you don't get that positive pregnancy test for a few weeks down the road. So at that point, the embryo is already a few weeks old, and those medications could have crossed the placenta. So if they were going to cause some kind of birth defect, some of that stuff has happened a little bit by the time you even get a positive test. So in an ideal world, if you're on chronic medications, just to touch base with your regular doctor and decide, are these good medications to be on if I'm trying to get pregnant, or should I optimize them with some safer choices for pregnancy, is a really good conversation to start early. The second piece of that puzzle is, we know if you get started on folic acid for at least 4 weeks before you get pregnant, it can reduce miscarriage rate by a little bit. Again, having that folic acid really well repleted in a woman by the time she gets pregnant will reduce the risk of neural tube defect and miscarriage. So when people come in, say, maybe you go to your doctor for the first time in pregnancy about 8 weeks, and they haven't started a prenatal vitamin yet, it's never too late. It's always time to get on one. But I do feel like women have that opportunity to get started even before getting pregnant, and that can really get those folic acid levels up and reduce the risk of miscarriage by a little bit, which is always super traumatic for anybody going through a miscarriage, and it's extremely common. So to reduce that by even a fraction is really good. Folic acid is really well tolerated by people, and there's not a downside to taking it. So I encourage a lot of people who are just, if they're using a rhythm method or condoms, or even people who forget their pill a lot or are feeling conflicted about birth control, there's not a downside of just taking a folic acid supplement once a day, just in case you get an unexpected pregnancy. I think of, in general, we divide pregnancy in terms of the 3 trimesters, and it's kind of like that for maternity care as well. In an ideal world, once you get that positive pregnancy test, calling to get established with a doctor, an OB, family doctor who does OB, or a midwife, is important to try to get that appointment on the books as soon as possible. For one thing, it's really nice to get those dates really well established, and we can get the most accurate dating ultrasound between around 7 and 10 weeks gestation. So if people come in like at 26 weeks pregnant with kind of not exactly sure when their period is, it's hard to know exactly when their due date is. And then hard to know exactly how far along they are if they come in labor. It might be plus or minus a couple of weeks by the time we get that dating ultrasound if you're in your second trimester. So getting in the first trimester to get your dating ultrasound, get your labs done to look for anything unusual that might come up, and then to control any chronic medical problems that are pre-existing are really important. If we also know about you and have you established, we can kind of get some of those early pregnancy discomforts that arise, nausea and vomiting in pregnancy, or even a severe form called hyperemesis. And if you're established with the doctor, it's just easy to get in. If you need IV fluids, if you need to have a medication escalation, we can help you navigate that. There's also some genetic testing that we offer in pregnancy as early as 10 weeks now. So for people interested in genetic testing, we can get that done early to look for some of the trisomies like Down syndrome. So that testing can be offered really early in the pregnancy, which has been kind of a change in practice in recent years. In the second trimester, it's usually kind of a quieter time in pregnancy. A lot of that miscarriage concern has decreased. Most people are starting to feel the baby move sometime in the second trimester. And a lot of the organs are already developed. So the fetus is in a little bit of a safer place in terms of the environment. We still see you once a month in the first trimester, once a month in the second trimester. And then starting in the third trimester, around that 30 weeks or so, we're going to be seeing patients every 2 weeks, and then every week at the end once you hit about the 36-week mark. Really important to be consistent with the appointments and come in, even though it feels like it's a low risk pregnancy. Some of the complications that arise are hard to know just by how you're feeling physically. We have some patients that come in that feel fine, but we're starting to see blood pressure elevate. And we want to know about that stuff early so that we can keep a close eye, get the appropriate investigations before anything becomes severe. Also, sometimes people feel fine, but we know that the baby's not growing the way we expected. A condition called IUGR, or intrauterine growth restriction, and that can be a dangerous state for the baby. So we need to know about it, trend out the growth pattern, and come up with a timing for how we're going to do some extra monitoring for the baby, and possibly even deliver a little bit on the earlier side, depending on different circumstances. I think a lot of people, as soon as they get that pregnancy test, are already thinking about delivery and have a lot of focus on the labor experience. And the truth is that pregnancy is so much more than that. Between that positive pregnancy test and the moment you deliver, there's so much that goes into it. And then the reality is that the labor, even though it's a very transformative and important part of it, is a very finite window of time also. And you have this baby the rest of your life and their life. And so, focusing also on as to how are you going to take care of the baby, making different plans for that. If you're interested in breastfeeding, maybe get some lactation books or doing lactation courses. Our Family Birth Center does a wonderful job with childbirth education. And there's tons of online resources out there, tons of books out there, different ways to digest it in kind of a small bites so that you're not overwhelmed when here you are after this long, hard labor, the baby's out, and suddenly you're like, and now what? So I think it's really nice to get that education part started really early in the pregnancy so that you can prepare yourself for what the next phase of your life will look like too.
Great. It's a great overview. Thank you so much. I have a couple quick things. I'm curious. Well, first of all, I guess a comment is that then the nice part about being a family practice physician is then you move from being the doctor for the mama to also the baby. Is that correct? Can you share a little bit about that?
Yeah, absolutely. One of the really wonderful parts about being a family doctor in obstetrics is that a lot of families come to me. So it's a lot of families that I know well who have brought their kids to me for well child visits. I already see the mom and I'm already maybe managing migraines or chronic hypertension. And so when they get pregnant, it can be a really quick portal message like, hey, I'm pregnant. What should I switch before my visit with you? But a lot of them, I've also had the opportunity at the well child visit. A lot of them have been like, by the way, we're kind of thinking about another kid. So a lot of people are giving me those kind of heads up just as part of their well child visit. So we have the opportunity for some education without doing a formal clinic visit, and there's some real advantages with that. Once the baby's out, certainly, no one's pressured to continue to bring their child to me. If they've chosen a different pediatrician, we have a wonderful group of family doctors here at Boone County Hospital, and they all love to see babies as part of their practice. So I feel like we're really, really fortunate in that regard that, if you've brought all your kids to Dr. Dunker or Anderson or Peterson from the get-go, just because you're seeing me for maternity care does not mean that you have to continue coming to me. By all means, bring this new baby, back to your usual family doctor or pediatrician that you've been following with. But, with those families I do follow, it's really nice because I can see, see the babies grow and develop into young kids. I think of it as a really amazing yardstick in terms of my own life or how long I've been here at Boone County Hospital, because now I see kids in kindergarten, and I think, oh, I delivered that baby. That's a reminder. Some days I feel like I just got here, and then it's a reminder that I've actually been here about 7 years. And when I see the kid in kindergarten, I'm like, yeah, it's been a hot minute since I delivered that baby. But it's a reminder of just how fast time goes, and what a precious moment in life it is to be there and share that delivery experience with the family.
Yeah, and then you get to be there for every stage and phase of each of their lives. So that's so great. And this, I hope this isn't putting anybody on the spot, but if you can't answer it offhand, I would open it up. But you talked about so many resources being available. And it's funny because it's been a long time since I've been having babies, and I look at all the things that are available to us now with phones and apps and being bombarded by all the resources. Is there one kind of steadfast one resource you would say, this is the book or the app or whatever that I would suggest to every mom that's, or somebody wanting to get pregnant or kind of know more about pregnancy and what to expect? Is there anything you would have offhand to share, Dr. Stevenson?
Yeah, my favorite book is The Mayo Guide to a Healthy Pregnancy, and I actually hand it out to every pregnant woman who comes through my office. It has it both broken down in terms of like a week by week segment and more information about, like, if you're interested in genetic testing, there's a segment that delves into a little bit more information. So you can either search by topic or by week. I would say the vast majority of my patients, there's a million apps out there that, like, pregnancy tracker apps, and I honestly think they're all good. I've researched several of them, and they've all been very similar and all excellent. It's the minority of patients that come in who haven't now put their last menstrual period into some kind of app. And they walk in the door and they tell me, okay, this is my app, and this is my due date, and I check it to make sure it's the same as what our computer does. Sometimes it's different by a date, but 90% of the time they're exactly the same. And they can usually even tell me, like, my baby weighs this many grams now and has developed fingers and toes. So people have a remarkable amount of information that they didn't used to have. So I think it's really wonderful to see women be empowered by technology and the amount of information out there.
That's awesome. Thank you so much. And I'm so happy to hear that you're giving everybody that Mayo Guide for a healthy pregnancy. That's just so awesome and such a great thing for us to be able to do here at Boone County Hospital in our clinic. So was there anything else you had to add before we move on? Thank you so much. Well, Dr. Linkenmeyer, that brings us to you in the next phase of a woman's life. So we kind of covered that early adolescence into reproductive years for people wanting to have babies. And then we start into those really fun years of menopause and peri and post. And can you elaborate for us a little bit on that?
Yeah, of course. So I'll just quick introduce myself. Hello, everybody. I'm Dr. Kate Linkenmeyer. I work with Dr. Stevenson, Dr. Hay. I get to deliver babies with them, but then just like those two also, we're family doctors, so we're helping at every part of someone's life. And that includes really tough transitions like menopause, right? And so, and I'll kind of start this by saying menopause is one of those unique things where every woman's going to go through it, almost every woman's going to go through it. But it doesn't mean that it's like this fun, enjoyable process that you have to bear through it. So, and I think that's one of the things I'll kind of recommend to patients is that absolutely you can reach out, see if there's ways that we can help manage symptoms, because there are really good options. And sometimes even just recognizing like, this is a common symptom, it's not abnormal, it's not scary. And I think that can offer some reassurance to people. So, but yeah, so menopause is kind of that interesting transition, right? It's like clearly defined that it's the complete ending of menstrual cycles for 12 months, so a full year of having no menstrual bleeding. And what's really frustrating is that there's that transition with it. And so people will start having irregular menstrual cycles, sometimes 5 years before that even officially ends, right? And that can be really frustrating, the unpredictability of it. And usually people are experiencing symptoms of menopause even when they start to have those irregular periods, right? And every woman's experience in transition can be really unique. If they look at like the most common number that people are when they officially have entered menopause and completed menopause, it's 51 years old. But there's lots of women that are entering into that transition, after the age of 45, kind of between that 45 and 55. And of course, there are outliers to that too. I haven't actually looked to check if the data is there, but I feel like so many people talk about how when your mother went through that transition is a pretty good predictor of when you would. And I still kind of go by that. Full disclosure, I haven't read to see how accurate that is and if they do studies. But it is a fair thing to kind of judge it on. So as far as those symptoms that most women are experiencing, I mean, hands down, the most common is hot flashes. Probably like 4 out of 5 women are going to experience hot flashes. Sometimes they're able to manage it, right, just by having blankets that they can easily remove, having fans in their office, whatever it might be, right? Sometimes it does become something that's just it's hindering their day-to-day. They're finding that they can't continue with work or can't go about their day-to-day. And so women a lot of times are seeking out different ways that can maybe offer assistance to them. Surprisingly, right, there are some really great kind of natural sources. I know a huge one that I talk to women about that's a very safe option to try is black cohosh. Actually, some really good evidence behind it, available over the counter, and definitely something worthwhile that women can be trying. Otherwise, as we get in, and we can kind of escalate cares as we go. And one of the biggest ways that we can, especially with hot flashes, if it is becoming unbearable, women always do have the option of replacing some of those hormones that they're losing, right? So they call that hormone replacement therapy. Your body is naturally going to stop making the estrogen and the progesterone, and so we can help replace some of that. This has kind of been this area that's been in flux for a long time, and I can talk a little bit more about that later. But so there is this wide range of options for women, especially for hot flashes, since that's the most common. But otherwise, women can be experiencing terrible insomnia with this, right? Maybe related to hot flashes, maybe not, just on its own, terrible insomnia. Very common that women can get mood symptoms, sometimes increase in anxiety. Depression is definitely very common in that menopause and that menopause transition. A lot of women will describe this brain fog. And as you can imagine, like everything is so connected, right? So is there brain fog because insomnia is terrible? Is there brain fog because the mind's racing with anxiety or depressive thoughts? And it's so intertwined, right? But we do know that a lot of women are experiencing brain fog and this kind of like just cognitive complaints, right? And concerns. Physically, some women are having a lot of difficulty with just the changes, especially with their overall vulvar health and including their urinal or like their urinary health. Very common that the vulvar skin is it's going to thin out a little bit. It's going to be easily irritated, right? Which means that sometimes urination can burn the skin. Skin might become much more sensitive to different fragrances, different topicals, different soaps, right? And very commonly that pain can develop with intercourse. And so there's definitely still really great options for that, including even just topicals, right? Some people find just using kind of topicals, different ointments and creams can actually help with their skin a lot and help with some of that pain. Lubrication really seems to help women a lot. There's wonderful therapies with, say, pelvic floor physical therapy, right? Positional changes, things like that. So there's still a wide range of options for women to consider with that. And then eventually too, you can always consider, is there benefit to replacing and putting some estrogen in that area? And that's where we have suppositories, creams. There are medication options for people too. Along with that, when we think about the urinary symptoms, right, as that skin is changing, it also changes how that urinary system and how that flow is. So it's not uncommon that if someone is having significant changes in their vaginal skin and their vulvar skin, they can have UTIs that keep coming back, recurrent UTIs, which is very frustrating and very debilitating for a lot of people. And once again, sometimes by addressing the underlying problem of the skin around there has changed, we can help with it. You also have changes on that pelvic floor muscle, and that's where you get really good benefit from pelvic floor physical therapy. So, yeah, I'd say that was kind of the big things with that. I made some little notes as far as, there are also some kind of like really very commonly heard things, although I don't know if the evidence is really behind there, but definitely women can struggle at that time with maintaining their weight or have it if they were hoping to have successful weight loss. Weight changes can be really distressing for some people. Energy sometimes is another one that people are just exhausted all the time. They can find a huge change in their energy level. So, and that's that transition. And sometimes just to support women through that transition, that's where you'll find success. And like I said, there's this wide range. You're not like, do this and not this, right? You can incorporate a lot of these different techniques. Yeah, I think that's the big thing in there. But then also as you go through that transition and as your body has gone through the transition, you have different changes in your health and different risks now to your body. And that's, I don't know if I'll have a chance to, I don't know if I know we're talking about mammography, but DEXA, is that coming up at all?
Yeah, you can talk.
Yeah.
Were you going to talk about the DEXA scan, or were you just talking about mammography?
I was just going to talk about mammography.
Okay, well, that's perfect because I can touch on osteoporosis, because that's something that so osteoporosis is when the bones are thinning. That really strong network that creates this good strong bone is just thinning out. And that's called osteoporosis. We can screen and test for this with something called the DEXA. We also call it a bone scan a lot. And this is a routine screening test that every woman should undergo. When you hit about the age of 65, you can go ahead and get that done. And it's a screening test. We're looking for signs of osteoporosis. There are things that influence it otherwise. And so some women actually will get screened earlier than age 65, but that's something you should always talk to your doctor about, is when is a good time to do that screening. Women are especially at risk because as estrogen leaves our body, it's natural that it's not going to be there to support that bone. So it's actually excellent for bone health to have that estrogen, but there's also dangers in having high level of estrogen. So we never just willy-nilly throw estrogen at someone. And that kind of gets to this really interesting thing. There's been this huge back and forth. As I was talking about hormone replacement, there have been huge studies that have had us flipping one way or the other as providers. So initially they found that when we give women who are going through menopause, when we give them hormones, their menopausal symptoms go away. It's fantastic. And then when they looked at everything, they realized, my goodness, there's also side effects with this, right? There's a potential for stroke risk. There's very significant cardiovascular, so your heart and blood vessel and your brain health, right? There's really significant risk factors with that. And so all of a sudden there was no hormone replacement. And then once again, they took a step back and they really looked at the evidence and they found, okay, we gotta stratify stuff. This is an excellent treatment. Of course, there are risks. We have to talk with people about the risks, see who's a good candidate and who's not. Okay, and so that's one of the things I'll say is that even though we know having the hormone replacement would help with menopause symptoms, it would help with osteoporosis, right? There's still risk factors with it. And that's that benefit of why we incorporate so much of this, right? And that's why you should be chatting and talking with your doctor about, well, what's unique to my history? What are my risks? What should I be screened for? And that's something I'll always encourage people to do, is check in and see what screening you're eligible for. And any provider is going to be willing to chat with you about that. So bone scans can start at the age of 65 or earlier if there's risk factors. The mammogram, which we're going to keep talking about. Mammograms, the Pap exams, which were talked about already. So usually we're going to age 65, but there's always special situations with that. You know, some people had a hysterectomy, they don't have a cervix. What do you screen for? And even that, some people are baffled at, because if your hysterectomy was for cancer, then you will actually continue with some of those Pap exams and that screening. But if the hysterectomy was for fibroids or something, or pain, or for some other reason, usually you don't need any further screening. Yeah, I'd say those would be the big things. But as women too, right, we're also much more than just our reproductive health system, right? And so I think recognizing too that as women we have kind of unique things. A lot of previous research on symptoms of heart disease and stroke and all these things, right, were based on looking at male populations, right? So now, thankfully, we have much more information. We know what those symptoms can really look like for men and women. One of my favorite things that I ever heard that I think is a really helpful thing to recognize for women's health later on, and that whole health, like cardiovascular health too, is if you've been pregnant and if you've had any difficulty with pregnancy, whether it was high blood pressure or diabetes, think of pregnancy as the ultimate stress test. So when we are assessing someone's overall heart health, we put that heart to work and we say, what can your heart do under really stressful moments, exercise and things like that? And with pregnancy, that's like the ultimate stress test. And so if you're someone who developed blood pressure or any heart issues during your pregnancy, it's a sign that you are showing signs that you'd be predisposed for this. You have a higher chance of having complications later. Not because of your pregnancy, but the pregnancy gave us clues of what your future might hold. And so I think that's really something important for someone to disclose to their primary care doc, to their family doc, is, when I was young and in my 20s, I had high blood pressure with my pregnancy. I had a complicated pregnancy because it shows I might be someone who's at risk for heart disease. Let's make sure we're doing my heart screenings. And so I think that's a really kind of helpful thing. Other screening tests would be if you're a smoker, you want to get something called a low dose CT scan. We can start those as early as age 55, 50, age 50, we can start those. Yeah, and all that stuff, right, is incorporated into women's health, right? So I think that's all important to know.
Yes, I'm writing down as fast as I can over here all this great information. So thank you for that. I have just a couple of quick things for you, Dr. Linkenmeyer. I guess maybe again more of a comment, but it's what I'm really appreciating too from hearing from all three of you so far is the mental health aspect woven in, and specifically from you, Dr. Linkenmeyer, when you're talking about the different symptoms and aspects of menopause. I think that previously it's kind of like, this isn't your grandmother's menopause, right? Like what we knew from our grandmothers was like, you had hot flashes and then you stopped menstruating. And it's like, there's so much more to it than that. And I think that it's so important that we're talking about it, and that you're also, sharing these things and these symptoms with people that I think sometimes they feel kind of like they're crazy, for lack of a better term, when the reality is this is very normal. It can be very normal part of that phase of life. So I guess that's more of a comment than a question. But and then my understanding too is that all three of you are accepting new patients, correct? I want to make sure we get that in there.
Oh yeah.
So yeah, if somebody wants to start coming to you as a physician, we just ask that they call the clinic and set up an appointment for a new patient visit, I assume. And anything else that we would want to add about that? Dr. Hay, looks like you're nodding.
As far as how they make an appointment with us, is that the question?
Sure, yeah.
Yeah, so you can just call our phone number for the clinic here, the North Clinic, at 515-432-4444. And kind of depending on what the situation is for what you're needing to be seen for, we will triage kind of how quickly you need to be seen and by who. But yeah, give us a call.
Great, thank you so much for that. And so we actually have three more speakers. This is what's been really wonderful about this program today, is that we're really encompassing all women's health. Some of these things have already been touched on, but I'm going to turn over to you, Dina. Dina is our director of Family Birth Center, and just having that kind of segue from all these phases of a woman's life to, okay, now we're pregnant and having a baby, and what does share a little bit about yourself and about our Family Birth Center here at Boone County Hospital, please.
I sure will. I'm Dina Sitzma. I've been the director of the Family Birth Center since 2011, and I've been involved in maternity care and OB care for going on 28 years now. So I really do have a love for it, and feel like the service that we provide to our community and the Family Birth Center here at the hospital is a really wonderful, exceptional opportunity for our patients in our community. At our hospital, we ideally deliver babies that are 35 weeks gestation and up. We do occasionally deliver a baby that's lower in gestation than that. It's not ideal, but we certainly are trained to do so, and we have partners with the Des Moines Hospital. So if we do need a neonatal intensive care unit, we can utilize their services in those scary situations. We care for the mom through her antenatally before she would have her baby, during labor and delivery, postpartum, and then even after they go home, we offer a 2-day well baby visit. So we get to spend quite a bit of time with some of our mommies who maybe start their antenatal testing at 32 weeks. Also, we have the childbirth classes beforehand. Our childbirth class encompasses childbirth, the whole process of childbirth, pain control, pain medication, and then also looks at breastfeeding and baby care. And then we also offer a sibling class for those older brothers and sisters to be able to learn a little bit what it's like to have a new baby in their home, see where their mom's going to be. And then they also get to make a little craft that is a gift for their baby. So it's kind of exciting for those little ones to bring that in when the baby has been born and get to see their new sibling. Labor and delivery, we always want to make sure that the patient has the birth experience that they want. And our goal is really to meet the needs of the patient, the desires, their wishes. We all know that not every birth goes exactly as planned, but all the nurses and the doctors on staff are going to do everything we can to really try to provide the experience that that patient wants to have. Um, it's very important. It's a very special time in their life. It's something that they're always going to remember, and we really want to be there for them to do that. The nurses on staff have extensive training in obstetrics and perinatal care. Everybody has fetal monitoring training. We're all trained in adult and neonatal life support, stabilization of our newborns. All of our nurses, one of our newer education things that we've been able to do over the last couple of years is have all of our nurses trained in spinning babies, which is labor techniques and positioning for moms to help her with her labor, to make her more comfortable, but also to help her labor progress. So it depends where the baby's at in the pelvis and how to help advance that labor along. So hopefully it's a little bit shorter for her and the baby. So we have a nursing staff that really cares about our patients and really wants to give that personal care. We don't do a huge number of deliveries in our organization. So most of the time when the mom is there, she has one-on-one with a nurse, and she gets really dedicated, personal, individualized care. Also, as far as labor support, things that we can offer for labor support, we have lots of natural labor support options. We talked about positioning, but moving, there's lots of research that shows that movement during labor really helps. We do have portable monitors. So if they do have to be monitored because of an induction or a risk factor, it doesn't mean that they are stuck in the bed. They can be up, they can move around, and they can do a lot while they're in labor. We'll work through relaxation and breathing techniques if that's something that would work. We offer lots of things to moms. Obviously, some things work for some better than others, so it's always what works for them, and we're going to individualize it to them. We have jacuzzi tubs in all of our rooms, lots of different positioners. We have a thing called a cub positioner. We have peanut balls. We have birthing balls. Lots of different tools and tricks to try to help that labor progress and keep that mom as comfortable as possible. And then nitrous oxide, which a lot of people think is a medication, isn't actually a medication. It's an inhaled gas. It's something that will help with labor pain, and it also helps with anxiety. So there's lots of different scenarios that we could use that nitrous in. Maybe they're really anxious because they decided they want to get an epidural, but they're really nervous about sitting there. We can pull the nitrous out, and they can use that to help with their anxiety. Or maybe it's earlier in labor and their contractions are uncomfortable. They can utilize the nitrous to help get through that early contraction pain. And some women use it all the way up through pushing, because the good thing about nitrous is as soon as you breathe out a couple of breaths, the nitrous is out of the system. It's not going to have any impact on the baby. So it's a really nice option. Medication is also an option. We have IV pain medications. Sometimes we'll do an injection in early labor if the mom just needs a little bit of pain relief and rest to get through those early contractions that aren't really doing much for her cervix, but they definitely are there and uncomfortable. And then we also offer epidurals and intrathecal narcotic, which is medication that goes into the back. They go into a little bit different space and they function a little bit differently, but those are a more aggressive. They're called regional anesthesia, and they really have a bigger impact on reducing that pain that the patient is experiencing. At birth, once the baby has arrived, we like to do skin to skin with our moms and babies. So that means when the baby is born, the baby gets placed right up on mom's belly and tummy. We dry the baby and we keep that baby right there with mom. And ideally, that baby is there for at least the first 2 hours after birth. If for some reason mom is needing a moment, we can have their partner, whoever that is, whether it's their husband, significant other, a friend, they can do skin to skin with the baby if the mom needs a moment too. So we encourage that with all the family members that are involved. And we encourage skin to skin throughout that first couple of weeks of life. It's going to help regulate that baby's temperature, heart rate. It helps to regulate the blood sugar. There's been studies that show that it actually increases the success with breastfeeding too, keeping those babies skin to skin with their moms. After that, we do our normal routine exams on baby. Something that we do on all babies is newborn screening, and that includes a metabolic screen that occurs at 24 hours of age. It's a blood screening, so they collect a little bit of blood out of the baby's heel. We also do hearing screening on all of our babies, and then a heart disease screening before they go home from the hospital. Throughout the whole process, we're providing education to our families. We know that this is generally a new experience, and even if you've had a baby before, every pregnancy is different. So there is never a dumb question. We always want to know what people are worried about. I'd rather have you be informed than sitting and worrying and concerned about a situation that if you just asked, I could have given you a simple explanation for, and you didn't have to be afraid. So always ask those questions throughout the labor birth process, and then postpartum, we're working with you on breastfeeding and baby care and how to take care of yourself postpartum after you go home from the hospital. And then 2 days after, we also offer a 2-day well baby mom visit, and we check mom and baby over and give the opportunity to ask questions and to provide education. Another resource that we have is breastfeeding support. So all of our nurses are well educated in breastfeeding, but we also have an international board certified lactation consultant and a certified lactation counselor. So if your breastfeeding concerns or issues come to be more than what the nursing staff can handle, they have resources to talk to, and we can reach out and help you. And that is before you have your baby, during your hospitalization, and after you go home. And currently all those services for lactation are free. So we are happy to help you. I think that about covers it.
Yeah, that's fantastic. And I really don't have any questions for you specifically, Dina. I just think that, again, it just really opens my eyes to everything that's available right here, close to home, the personalized service that we get. And I'm always happy to share my testimonial. It's been a few years, but have had a baby here, and it was an excellent experience. And just can't say enough good things about it. So it's really wonderful to just see the practice, especially continue to grow in terms of getting that lactation consultant who's an international certified, I think you said, and it's just, keeps getting better and better all the time in terms of what we can provide. And I just think it's a great thing. So thank you for your expertise. And that leads us to our last couple. We're going over a little bit longer than I thought, so hopefully you're okay on time, everybody here. But so Sarah, do you mind sharing with us a little bit about what you do in the radiology department and for 3D mammography?
Yeah, so I've been at Boone for maybe 2.5 years, and then I've been doing mammo for a little over a year. So we do 3D mammos. We got our mammo machine that we have now in 2017. Since we got that machine, we've done about 10,000 exams on it. So everyone after the age of 40, any women will start annual screenings. If they have a reason to come in any earlier, they'll talk with their physician about it. If they have any increased risk of getting breast cancer due to like a family history maybe, then they can start coming in. And then we don't really have a set age that you stop getting your mammo screenings. It's really when you decide you want to be done. We're not going to force you to keep coming in, but we'll be happy to keep doing it as long as you want to come in. So since then, we've done about 189 biopsies since we got our new machine, and 63 of those biopsies actually turned out to be cancer. So if the doctor sees anything that, or the radiologist sees anything that he thinks would be suspicious enough to biopsy it, that it could possibly be cancer, we can do different biopsies here. And then we also, our radiologists are from the McFarland Clinic, so we work with them too to get some biopsies through them. I mean, other than that, I don't really have a whole lot like everyone else does, but usually our exams for screenings, they take about 30 minutes, and the actual pictures themselves only take maybe 10 to 15. Some people say there is a little bit of discomfort, but it should never be unbearable for the patient at all.
Great. Yeah, that's great information. You covered, I think, all of it. I think the only thing that I'm curious about, Sarah, is when people schedule an appointment, can they just call? Do they need a doctor's referral? How does that work in terms of getting set up with an appointment here at Boone County Hospital for 3D mammography?
Yeah, so if they are just having a normal screening exam, they don't need a patient or a doctor's referral or anything like that. You can be self-referred for those, as long as they're not having any breast concerns that are happening. If they have a lump or a bump or anything like that, we always say you have to go through your doctor, get a referral sent over here, and then we can actually do your exam, because it'd be a little bit different than just a normal screening 30 minutes in and out. We'd want to talk with the radiologist and just make sure we're doing basically as much as we can while you're here to get everything looked over. And then the patient access is who will schedule our exams. So they ask all the right questions and figure out what exam is really needed.
Okay, great. That's super helpful. Thank you so much for your knowledge and expertise, Sarah. And I think that leaves us with Carolyn. So Carolyn, we're rounding out our program today with you, talking about physical therapy and specifically for women's health services. Are you ready to go for this now?
Yes, yep. I'm Carolyn Siskoff, and I have my doctorate in physical therapy. I've been a physical therapist for almost 14 years now, and I've been at Boone Rehabilitation Services for 6 years. I have personally been treating incontinence and pelvic floor dysfunction for the last 5 years. I became interested in trying to treat that segment of physical therapy, as with my first child, I had severe 4th-degree tearing, and so I needed about 9 months of this kind of therapy myself. And so I was very appreciative and grateful for my physical therapist, and I understand the uncomfortableness of being treated for this area and just the dysfunction it can cause in your daily life. When I came to Boone, there was nobody treating this anymore in physical therapy, and so I took some continuing education and started to treat patients in this population. I can also treat everybody kind of head to toe with the normal diagnoses that come to physical therapy, as well as I specialize in vestibular rehab too. So in physical therapy, in order to be seen, typically we do need a referral from a physician. Blue Cross Blue Shield is about the only insurance you could walk off the street and be seen, but most of the time we do like to have that from the physician. Just insurance is more likely to approve it, and it could be from your primary care provider, your OBGYN, a urologist, a nurse practitioner, or another specialist that you are seeing for it. With the pelvic floor rehab, I can treat urinary incontinence and fecal incontinence, constipation, pelvic prolapse, vulvar pain, dysmenorrhea, dyspareunia, endometriosis, pudendal neuralgia, and painful bladder syndrome. I can work with patients pre-partum or pre-pregnancy and postpartum. And I can treat the males also with these diagnoses, but definitely I see more females than males. I like to work with people at any age group, as we know that none of these issues are normal with any stage of life. And as we've kind of talked about the whole spectrum, I myself personally don't have a lot of experience with the pediatric portion of physical therapy, but certainly talk with your provider and they can refer you to a physical therapist within the area that can. Otherwise, I certainly have worked with people who are pregnant and working through if they have some pain in their pelvic region or low back, and resolving that. Also just learning the proper muscles to use during labor and delivery. We've talked about relaxation, being able to relax those muscles, deep breathing, using your diaphragm and your abdominals efficiently to make the birthing process as easy and comfortable as possible and minimize damage afterwards. And then I can, yes, postpartum treat. The wider range of physicians have started to be really good about saying, hey, you're a little weak in this area, and let's go see physical therapy and learn how to turn those muscles back on. Muscles kind of stop being used after trauma of childbirth. And sometimes it's just we need to reconnect the process of the muscle and the brain and become more efficient in using them so we can prevent things from happening down the road 20, 30, 40, 50 years later. And I also then work with the wide spectrum of ages with incontinence. Oftentimes patients assume that physicians don't ask about it. They only leak just a little bit or once in a while. They think that other people are worse off than them, and so they don't want to waste their time or my time. And they just don't talk about it. So they assume, the physician didn't ask about it, so it's not important. And there's nothing else that can be done, which is absolutely not true. At any stage of, especially the incontinence, both urinary and fecal, and constipation, there's a lot of things that we can do. And I'm actually more effective earlier in the stages of the dysfunction than the later aspect of when I'm trying to just kind of manage the symptoms versus I can maybe cure them or reverse them. There's certainly times people will have hysterectomies or joint surgeries, and the surgeon that they're seeing really is just concerned about did they heal from that certain surgery. And oftentimes the incontinence issues, or again, just the lack of being able to use those muscles goes undiagnosed, untreated, and they might be having function or dysfunction with moving, getting up out of a chair, getting out of their bed, and they leak a little bit of urine, but the physician doesn't ask about it, so they assume that's normal, and it's not. And there's lots of different things that we can do to treat that and eliminate it. With patients, I do sit down and I take a history and I get to know them. I look at their range of motion and their strength, kind of from their shoulders down. And I work within everybody's comfort level. There is a very private treatment area that I can work with them, and there is a bathroom right in the room, so that's very convenient. I look at their diet, their medications, how much hydration they're having in their day and how that can affect them. I work at bladder and bowel retraining, suppressing the urge, I really got to get to the bathroom now, techniques to how to suppress that and make it to the bathroom relaxed. I ensure that their Kegels, their exercises, they are doing correctly and at the appropriate dosage. Certainly, as it has been said, that yes, there are things, apps and Google that can provide a lot of good information. However, I run into people say, oh yeah, I looked online and I found out how to do Kegels. And they're just like medication, exercises have specific prescriptions also. If you're doing them too much, not enough, maybe you're incorporating your glutes and your abdomen instead of the pelvic floor muscles, then right, those Kegels aren't going to work for you. So that's where I step in and let's make sure you're actually doing a Kegel how it's supposed to be and at the right intensity for you to be effective with it. I can work at decreasing pain in the pelvic floor, certainly with a wide range of diagnoses, as well as intercourse can be discomfort, and we can look at positioning. Maybe their tissue is tight and need to stretch it out, so making that more comfortable. Also looking at balance, improving their core muscles. Oftentimes I kind of get to reduce their back pain, or again, make it easier to get out of a chair. Treat other things that they really weren't planning for me to treat, but it's kind of hard to do without looking at the person as a whole. We do have a brand new system for the pelvic floor that provides internal and external biofeedback, as well as electrical stimulation, both vaginally and rectally. So sometimes that is needed or helpful with our plan of care, not always. And I can get those for people to use in their home if need be. Certainly there's vaginal and rectal dilators and weights. Typically those things are not necessary, but I can assist somebody to get them if need be. Ideally, I do assess and work internally at times, but I am able to work externally with clothes on to help make people more comfortable. So it definitely has a different feel and look than what you would come to see me for your shoulder or your knee, but I definitely work with your comfort level with it. I typically see people for about an hour once a week, and certainly we can see them more or less depending on their need. How long, it really just depends on the person. Again, if you're seeing me more early on, when the trouble is starting, it's going to be a lot fewer visits than somebody that's coming. They've been leaking for 30 years when they started having their baby, when they had their baby 30 years ago. It might take us 6 months, 9 months, a year to really get to where they want to be. And of course, I keep their goals in mind as well as what mine are for them. There is a new study out from the American Physical Therapy Association. It just came out in September of 2023 on the economic value of physical therapy in the United States. And they did use an independent research group to look at 8 different conditions within the physical therapy realm services. And stress urinary incontinence was one of the conditions that they looked at, which is involuntary leakage of urine during exercise, coughing, sneezing, laughing. And it affects estimated 15 million people in the United States. They compared it to a common treatment of urethral bulking and included 7 different treatment options. And they found that the average net benefit of treating stress incontinence with physical therapy compared to the urethral bulking saved a $10,129 amount per episode of care with that patient. So, and it also found it was very cost effective for the other 7 diagnoses they looked into. So physical therapy, yes, is showing that it can be very cost effective and improve a person's quality of life, just in a much greater, broader spectrum too. Any other questions?
I have a couple of things I was going to ask you about. And first of all, I was going to ask you about what the kind of a typical appointment looked like. So thank you for walking us through that. I think that really helps people to kind of have that understanding of what that looks like. It also sounds like it can really be any age group, or not just in men or women, which is also really helpful to know. And that you're also using some updated technology, it sounds like, as well, with the new biofeedback system in home. And I think, what was I going to ask you? Oh, I know what it was. I think ultimately what it sounded like you were kind of getting to with all of the opportunities for physical therapy is to avoid a surgery. Would that be a safe assumption, or can you expand on
Correct.
that?
Yep. Ultimately, right. Come and see me first, and let's see if you possibly, right, do not have to have that surgery for especially overactive bladders, pelvic prolapses. Oftentimes those early stages 1 and 2, I can be very effective in eliminating and reducing kind of all the difficulties that come with it, and not have to undergo that. A lot of times too, they're looking at certain medications, which can be effective, but they also, every medication comes with a side effect. So if we can do a more natural approach and eliminate those, we can be very, very effective with that also. So cut down a lot of comorbidities and just risk for infection, post surgeries, improving healing. And also too, if we are trying to prevent the surgery and we are not effective, we really have not wasted our time, because having stronger muscles in that area, learning how to use your core muscles better, is going to help you post-surgically just come out of it and have it be more effective too. So
such great information and so helpful. Thank you, Carolyn. Really appreciate that. And if there isn't anything else anybody thought of, I'm just going to go ahead and wrap up. Any additional comments before we go into wrap up mode here? Okay. Well, I just want to take a moment to recognize each of you and thank you for your time today, but also the care and expertise that you bring to our patients, our community. I hope that we get this out far and wide to all the people that need to hear these messages about maybe they're having questioning whether or not they should be coming in for this, physical therapy or their mammogram, or just even getting them affiliated with our physicians to have them be able to help them through each stage and phase of life. So just really grateful to each of you for taking the time to be here today and to share with us. And thank you. We'll hopefully have you back again in a year, and we'll see what's new in the world of women's health services.
Thanks, Sarah.
thanks.
You're welcome. Have a great day. Take care.
Bye.